Welcome back to the Dr. Melanie Show. Today we're talking about pain management. Can you tell us, Dr. Joshi, what kind of interventional treatments there can be done for IC patients?
Yeah, for IC patients, there are a few interventional options that are available, and just like anything else, they may or may not provide amazing relief. But the things that are available, number one, there's something called a hypogastric plexus block. And what that is the hypogastric plexus is a sympathetically mediated plexus that sits in the on the anterior side, so in front of the spine around the L5-S1, which is all the way down at the bottom of the spine. So it's in a very sort of interesting location of the body. Can be somewhat challenging to get to, but a trained interventionalist should be able to do that procedure. And what it is, a lot of times when people have IC, they may have pure IC, they may have IC with other comorbidities, or they may not have IC at all. But one thing that the hypogastric plexus blocks allows you to do is allows you to be diagnostic in the sense that it allows you to find out if there's any sympathetically mediated component to that pelvic pain or that bladder pain. And there are some long-term options that you can use, something called radiofrequency or pulse radiofrequency, that can help for many, many months if that simple block, and the block is done with numbing medication, so there's nothing fancy that goes in there. It's just numbing medication. It can act as a diagnostic as well as a therapeutic block. So that's one option that's available. Another option that's available, and this we see actually quite frequently, is a lot of patients with IC pain, or either they have IC pain or they don't have IC pain, but they have something called pudendal neuralgia. Pudendal neuralgia is basically a nerve. It's a pudendal nerve, which is a nerve that's in the pelvis, is responsible for innervating or transmitting pain from a lot of pelvic structures, so anything from the bladder or the groin area all the way from the front to the back of the groin. So a lot of pain actually can be very sensitive pudendal nerve pain, or the pudendal nerve got injured or it had scar tissue, or it's being irritated by maybe inflammation throughout that area. And so the pudendal nerve block, and there's actually about 5 different ways of doing a pudendal nerve block, and really it's just dependent on where we think that the pain is, where we think the nerve's being impinged, or where we think the pain's coming from. But that can be incredibly helpful as well, especially if the patient has pudendal neuralgia. I mean, it can literally be night and day within a day or two. It's like a night and day response that the patients can have. The third thing that's available, let's say everything else fails and they've done the bladder installations and we've tried different blocks and tried different medications, et cetera, et cetera. There are some implantable stimulators that are available. You can either use an implantable spinal cord stimulator or an implantable interstim, which is basically a stimulator lead that sits on top of a few different nerves in the back. And those nerves are basically some of the nerves that help transmit pain from the pelvis, through the spinal cord, up to the brain. And you're trying to override painful signals with non-painful signals. If you think of your spinal cord as a train track, there's only one train that can go, or 2 trains that can go at a time. You can either have the painful train or the non-painful train, and so that's where stimulators come in and help, sort of transmit that non-painful train to the brain as opposed to the painful train to the brain. Those are 3 of the most common things that can be done. Obviously, there's variations on all of these that can be performed. But something to definitely, especially for all the IC patients that are listening, definitely something to at least bring up. It doesn't mean that it's necessarily appropriate in your situation, but something to bring up with your pain physician. So at least it sort of allows him or her to sort of think, well, gee, I wonder, is this what I think is going on? Is this something that might be helpful?
Okay. When somebody comes to you who has been at the top of the pain management tree of all the various things they could do, what do you have to offer them? Is it just the things that you've already talked about, or, you got to get them off all this addictive stuff? What do you do?
Yeah, and when you say the top, I'm assuming that they've sort of tried everything. Is that right?
Well, I'm talking about they're up to like the fentanyl patch, or they're on the morphine and.
Yeah. Typically, what I typically usually see is when a patient is sort of on everything, or on a really high dose of medications. Obviously, what it's telling me is obviously the the patient's had pain for a while, and their physician was kind of just I'm assuming was sort of just trying to treat it with maybe more narcotics.
Yes.
In an effort to try to get the patient relief. What we usually find is obviously the patients don't necessarily want to be on all those, but they really have no choice. They're like, look, I just want my pain to be better, and I don't know what else to do. So in those situations, again, we will introduce some adjunctive medications, and it's not just the introduction of those medications; it's really the mix. I sometimes describe it as making soup. You can have a bunch of different chefs, and you can give them all the same ingredients. And one guy might just might make soup with only carrots, and chances are it's probably not going to taste that good. But the guy who makes soup with all the different ingredients and different veggies and different spices and whatever, probably will taste better. And that's kind of where you see multimodal pain management come in. It's really how are you balancing out the different medications so you're maximizing efficacy, minimizing side effects, minimizing the amount of narcotics and opiates that are used, and introducing interventional options too, if appropriate. Okay, only if appropriate, obviously, and trying to sort of plug away or chip away at that pain. 20% here, 20% there, 20% there, and before you know it, you have actually a substantial sort of relief situation. So when I see those patients that are on a bunch of stuff, I'll sit down, I'll talk to them, try to figure out what's the most appropriate thing to do, and really present that to them and say, hey, listen, our goal is to increase function, reduce pain, but also reduce the amount of opiates or narcotics that you're on. In theory, it's one way. Obviously, there's every patient is different, right? So in some patients you can hit a home run or a grand slam, and in other patients you're struggling just to get to first base. Every patient is different, and some patients are unfortunately just the problem that they have is extremely complex and very resistant to treatment. So, but you still have to sort of give it your full effort.
I understand. Well, while we've been talking, we've had a number of callers call in, but we don't have time, unfortunately, to have them call in and talk to us. So I have instructed our engineer, thank you, Chad, to tell them to go to www.nationalpain.com, and then they can contact you through that website. And lots of people have questions. So, Dr. Joshi, would you be willing to come back another time and answer questions of callers?
Oh, absolutely. Absolutely. I'd love to help.
Okay. Well, I'm so glad. Today has been extremely interesting and very helpful to many people, and I hope that you will pass the word along to other people that need to hear this, because it will be rebroadcast 12 hours from now, and you can download it to your MP3 player or to iTunes.